Can you hear me? I think the history bit of it has been dealt with everybody, and so this is a detailed history. As the slides go by, you can share this. This is basically epidemiological information, demographic information, and some clinic history that needs to be collected from COVID patients or those that you're screening through. And Jyoti went through this very nicely. So what is laparoscopy? The controversy between laparoscopy and open surgery, is it really sorted out? The answer is no. Nobody knows the real answer, whether we should still be doing laparoscopy surgery. And I think it is important that we individualize the approach and the timing of surgery by balancing the risk of disease progression, i.e. if you wait and cancers or inflammation progress, and the risk of surgery and aerosolization, that really makes a difference. I think I like this indication, as I had mentioned in my previous talk. This is from the American College of Surgeons, and it says that goal is to provide timely surgical care with optimal patient care resources and preserving the health of caregivers. So everything, you have an onus to the patient, you have an onus to the caregiver himself and to yourself to provide a safe surgery. As long as you can balance these tripartite missions, then you're actually doing well. Because if you do laparoscopic surgery, we know we have a shorter length of stay, we have a lesser readmission, lesser harm to patient, but then there is an increased risk to staff potentially, and obviously for patients who have failed medical management, then surgery, whether that's open or laparoscopic, is indicated. So I think the brainchild behind all this is the surgeon himself. We all train from novice to become expert, and this is really where your expertise comes in, assessing whether you can create that balance with laparoscopic surgery. But do remember that the risk of aerosolizations are higher in laparoscopic surgery. So this is just a simple video, and this is an open bipolar diathermy, and to show you that even in open surgery there is plume formation. So if you go away with the impression that plume will not form in open surgery, that is wrong. Trocar insertions are great. You can use these trocars which have balloons at the end, and they will hopefully prevent a leaking port. There are other ways of using system. This is an air seal system. This is called the ConMed air seal system, where it is sealed. The air circulates in the trocar here and does not let it escape. The utilization of carbon dioxide is less. The pressures are operated at very low. The smoke evacuation mode allows to smoke evacuate. So these are, and the filter at 0.01 micro ULPA filters, which you can see can actually cover COVID filters as well. Try and use disposable instruments where possible. Why? Because on reusable instruments, there is consequence of residual viral load. All right, and try not to use disposables as reusables. As you can see here, despite cleaning them, you will still have a viral load in presence. Can you use reusable instruments? The quality of the instrument, one, reduces over time, and because particulate elements and aerosolized things can be left within the reusable instruments, the risk of having or breaching sterility is higher, and thus conveying infection is higher in these patients. Reduce the Trendelenburg position when you're putting patients in pneumoperitoneum, because it may compromise respiratory function. Obtain minimal pneumoperitoneum at low flow at pressures of 10 or 12 at the max of millimeters of mercury. Try not to increase, because as you increase pressure, it decreases the abdominal and the lung compliance and also increases the chances of leak. Pneumoperitoneum, try to ensure that you use them using clean trocars, and the incision sites are small so that they can be airtight when you do that. And I think one of our great speakers, Mahir, is going to speak about, if you don't have these fancy trocars that I talked about, how you can create a very nice air seal, and I leave him to do that great job. Now, this is to show you that even a simple ultrasonic energy device also generates plume. You can see this plume that has been generated by an ultrasonic device. So we take care of this. So what do? You basically suction more frequently so as to keep the field. use HEPA filters, and I'm not going to go into the details as Davide will talk about this. However, the ULPA filters are able to clear coronavirus, although there is no level 1 evidence to this. It's just based on size. And this is how it looks like. This is the rapid evacuator or the SOM evacuator system. And this is how it looks like in our theater. And again, I'll leave David to deal with this. So managing surgical plume, all pneumoperitoneum should be safely evacuated via filtration system, as you saw. Before closure of trocar removal and extraction and conversion to open, empty the abdominal cavity of whatever pneumoperitoneum is there. Just don't make an incision and let everything fall apart after doing laparoscopic surgery. Avoid long dissecting times, do shorter operations, avoid sharp injuries to your protective equipment as well while passing instruments. Instruments should be clean and blood-free. Use slow short burst of energy, because the more longer you burn, the more longer the tissue goes from a coagulative mode to a charring mode, which generates more plume. And remember that the low temperature of the aerosol does not effectively kill the virus. Concerns with MIS basically are droplet contact, and as Somani mentioned, and I would like to stress here again, that fecal-oral route is important. And when we do GI surgeries and burn tissues in GI surgeries, we can effectively aerosolize these tissues, and they can actually be a source of infection. So it's not that the virus does not live in the GI tract. I think Raj will deal with this active COVID-19 thing. Last but not the least is occupational hazard teaching. Please educate your people, practice proper techniques, strengthen an awareness of hazard caused by smoke, management of intraoperative aerosol. Strict protocol must be established for the creation and maintenance of pneumoperitoneum to reduce the occupational hazard. So exercise clinical judgment. This is the most important time where you can differentiate an expert from a non-expert, and that's why all COVID surgeries or in suspected cases or high-risk areas should be called on by the specialist to do. And there is insufficient data as of now to recommend against or for open versus laparoscopic, so exercise clinical judgment again. I come to the end of my talk with that, I think.